Welcome, everyone. So I'm going to mainly discuss the placental pathology, what we have in the literature as far as what's been associated with neonatal encephalopathy in the past. The papers vary quite a bit, so I'll try to introduce you to all the major categories of placental pathology that you'll find in the literature, as well as other things you won't find in the literature because they're very rare. But if you have a case of it, you're likely to have a child who has a poor outcome. So as you're all very familiar, the placenta is essential, especially near birth, right? It's our source of oxygen, carbon dioxide, and elimination, source of energy and nutrition, discharge of metabolic waste. I mean, it handles the function of countless organs, right, in utero. And when you compromise placental function, then you're severely compromising that infant or fetus. That's what it would be. So just to give a background in placental examination, not every placenta gets examined, although there are a few institutions, for example at Mass General, where a pathologist actually does look at every placenta and decides which ones will get a full examination and which ones will not, based on gross exam. That would be really unwieldy in our system with so many hospitals and so many deliveries, but there are places that do manage to do that. Recommendations for placental triage, which ones should get examined, vary very much across institutions and across the country. In the United States, we have a recommended triage system from the College of American Pathologists, but we don't actually have one from our neonatology community or from the obstetrics and gynecologic societies. It's been just generated from pathology without help, really. So I think that's something that we should be looking at. In the UK, in contrast, they did have pathologists and neonatologists and OB-GYNs get together and decide what criteria. It's a very different system. Obviously, that's a system that's resource limited. There are very few perinatal pathologists available to do the examinations. There's only so much money in the system, and they're very restrictive in terms of which placentas will get examined. But the bottom line for their system is pretty much any placenta associated with a sick baby gets examined. But placentas who may be associated with a baby born at 35 weeks but otherwise doing fine may not be examined. Whereas in the US system, under the College of American Pathology guidelines, that would be an indication for examination, late preterm birth. So they vary a lot. But across the board, it's always warranted in the case of a sick baby. And that's generally understood as a baby that's being admitted to the NICU, low APGAR scores, prematurity. That definition will vary. Again, some places will say less than 33 weeks and other places will say less than 37 weeks. IUGR in the USA, that may be defined as less than 10%. The 10th percentile for growth, whereas in Europe it may be the 3rd percentile, right? So much more restrictive in other situations. But a good rule of thumb always is to store the placenta from every birth for at least 48 hours. So that if everything seems just fine after birth, but then this baby is showing signs of seizure activity or develops a fever or something like that, then the placenta can be informative if it hasn't been thrown away and submitted for pathologic evaluation. And they do fine in the refrigerator. They don't get horrible artifacts or anything. You can store them and then submit them. And I know we're trying to work that system here, but that's a really important one. So it may be submitted to us fresh or in formalin. Just general aspects of the exam, because this reflects, in terms of what outcomes are reported in the literature, depends on what they did, right? What they looked at. But in general, the recommended standard exam includes examination of the umbilical cord. We're looking at the total cord length. We're looking at the average diameter, how the cord inserts on the placenta, how coiled is it? Does it show normal coiling, or is it overcoiled or undercoiled? Are there any focal lesions like a true knot? We're looking at the membranes. Gross exam mainly, you're just kind of looking for color and the type of insertion. Sometimes that can tell you about chronic abruptions. And then the disc itself is where most of the pathology is that matters, in addition to the cord. If you've got a serious cord problem, then you've got a serious problem, right? Because it's a lifeline. But in the disc, We're measuring it, we're getting weights standard to compare with normals, right? We look at something called the chorionic plate vasculature. If you look at this little image, right, here's our umbilical cord coming down, right, with our paired umbilical arteries in our vein, bringing back the oxygenated blood. So these first branches of the umbilical cord are called the chorionic plate vessels, right? So pathology in any one of these vessels can have a significant effect on a large amount of the placenta. So that's why we pay close attention to them, all right? From there, the vessels dive down into what we call stem villi and then out into the terminal villi. So similarly, a lesion in a stem villus vessel may affect a whole cotyledon downstream, right? That may be significant if it's a small placenta with other challenges to begin with, or it may be insignificant if it's an otherwise well-grown, normal-looking placenta. Okay, so we look at those. We also look at the maternal surface of the placenta. Obviously, the placental abruption, we'll see changes there. We may see hemorrhage behind the placenta. We look at for other lesions of the basal plate, and also color can tell you some things. You know, if they look, for example, studies of twin-twin transfusion syndrome, the donor twin side may look pale, and the recipient twin side may look dark red. Then we look at the parenchyma on cut section, and the color again reflects fetal blood content. So even though you've got two bloods in the placenta, right, you've got the maternal bathing the villi and the fetal blood within the villi, the color on cut section is due to the fetal blood content. So pale areas are concerning because that means fetal blood didn't get to that region. And then we also look for lesions. There are recommendations for routine sectioning, and these really came out. Finally, we have an international consensus about what sections should be submitted, what should we call things, and that was done in Amsterdam. They met in 2014, a group of experts, and published a consensus statement in 2015, and in that they recommend that we have 1 to 2 sections of cord. Here we always do 2, one of the placental end, one of the fetal end. 1 to 2 membrane rolls, we always do 2 because you have a higher likelihood of getting lesions. And 3 representative sections of normal looking parenchyma, right, to try to get your idea of what is the health of this organ, what's the background of this organ. That can be done with just 3 complete full thickness sections of the disc. Or for example, here we do 2 full thickness sections, one where we're sure to get a good representation of those chorionic plate vessels, and another where we're getting multiple representations of the maternal surface. And then always representative sections of lesions. Amsterdam criteria, they didn't say you had to sample every lesion. I do. I think it gives us a much better idea of how much parenchyma is involved by what. Because gross exam doesn't always tell you exactly what the pathology is. Okay, I promise it's not all black and white text in this lecture. So now we're going to go to the major pathology conditions that are associated with neonatal encephalopathy, right? So the literature for years has talked about chorioamnionitis, amniotic fluid infection, right? We know this is a major pathology in preterm birth. It's most often seen in the setting of preterm premature rupture of membranes. But we realize now that it overlaps with findings of maternal vascular malperfusion. So it may not be that, it can be, especially at term, that that's the only pathology you see. But in the pathologic scenario of preterm, often it's coming along with other changes. And it suggests that something's happening at the root of placentation, right? That things aren't remodeling well, and it's more vulnerable to a preterm birth. So in amniotic fluid infection, I use this with comfort in the preterm setting. At term, not every chorioamnionitis is associated with amniotic fluid infection, but preterm certainly it's much higher. And if you see lots of inflammatory responses, especially a fetal inflammatory response, it's much more likely to be associated with an actual organism. May not respond, you may not be able to get it from culture, but PCR methods would show you the organism. So we have 2 persons in this organ, right? And we can see a maternal inflammatory response, and that is chorioamnionitis, or a fetal inflammatory response, and that's inflammation in the umbilical vessels. Used to be called phenocitis. We're a little bit more descriptive now, trying to say which vessels are involved, because it correlates somewhat with the how long the inflammation is going on. And the chorionic plate vessels, those themselves we were talking about, you see a fetal inflammatory response there as well. That chorionic, the fetal vessel inflammation especially gets significant when you've had so much endothelial injury that you get thrombosis of the vessel. So if you're looking at significance of chorioamnionitis at term, the babies who have bad outcomes are usually the ones who've had thromboses associated with a severe inflammatory response, which makes sense. I mean, then you've really activated all kinds of inflammatory cascades. Some perinatal pathologists will grade and stage the involvement. It gives more information about the severity of responses and the duration. Okay, so this is a placenta with severe chorioamnionitis. We recognize that on gross exam because the membranes look milky white, right? Because there's so much pus around, basically. Histologically, this is the maternal response we're looking for. So these are neutrophils. They're responding to a stimulus up here in the amniotic fluid. This is the amnion, right? That's lining the whole sac, the amniotic cavity. It's very interesting to me, the demarcation that you see, because not all of them will go up above. Sometimes it's like this very strong physical limit right here. And we know that there are a lot of innate immune mechanisms that both the chorionic trophoblast and the amniotic epithelial cells themselves express that can tamper down inflammation and actually fight infection. So it's kind of interesting. You wonder how much of that is related to this limit we sometimes see to the response. This is a case of bad fetal inflammation, right? So this is a chorionic plate vessel histologically. So the baby's blood is trying to go through this vessel to get down to where it needs to go to get oxygenated. And we have this intense inflammation of the wall. It's up here heading towards, again, the amniotic fluid up here. The responses are always towards the amniotic fluid, towards whatever inciting factor is in there. If you look, you'll also find neutrophils in the fluid itself. People have wondered, are they fetal, are they maternal? You'll see both of them because both are sending this response towards it. And depending upon where you sample it, you may find enrichment of fetal versus enrichment of maternal. Oh, sorry. So that's one major category. When we talk about amniotic fluid infection, we're talking about ascending infection and the fetal and maternal inflammatory responses that are associated. Another major category is what we call maternal vascular malperfusion. So we have a maternal vascular malperfusion and a fetal vascular malperfusion because both circulations are coming to this organ. And you can have pathology associated with problems in either circulation. So maternal vascular malperfusion is the classic pathology giving you a small baby and a small placenta, right? This is classically what's been known as placental insufficiency. Though really anything that knocks out your parenchyma gives you an insufficient placenta, but this is the classic one. And it's due to insufficient or inconstant perfusion of the placenta by the uterine vessels, particularly the spiral arteries of the endometrium. The changes we see in pathology might be acute or chronic, right? So acute ones, you may not have a small for gestational baby or a small placenta, but you may have acute abruption that's separated, right? Or also acutely, you may just see the villi responding to ischemia with increased syncytial nodding or an acute infarct. But you can also have chronic changes, and chronic changes will usually give you a small for age placenta, so it's limited in its growth. And the villi show fascinating accommodations to this chronic insufficiency. It's very interesting to me because I always kind of think that these changes don't happen by accident, right? There must have been some evolutionary advantage somewhere along the way that in some setting, speeding up the maturation of the placenta was advantageous, that a shorter gestation somehow was advantageous. It must be somehow regulated by gene programs. But they're very interesting cases. It's a small placenta. The villi mature way too quickly for age. Sometimes they mature too quickly with significant compromise of the total amount of villus parenchyma that's available. In these cases that are chronic, you usually see abnormalities of the maternal spiral arteries themselves, so they didn't transform appropriately as they were supposed to for pregnancy. Okay. So this is what we may see on gross exam in these kind of cases. These are slices of the placental disc that are laid out. And this is a big old infarct. Not old, it's fairly old, subacute. But this is a big infarct with central hemorrhage, and this is what is called infarction hematoma. Infarcts can be very common in the placenta. Particularly, I have a friend, Drusilla Roberts at MGH, who studied thousands of placentas in Africa and says, they don't have them, but we have them all the time here. That may be related to maternal age differences because they are associated certainly with older maternal age if you look at literature. In a normal term placenta, you may have one infarct at the margin, so usually a centimeter or less. So sometimes I just won't even report that as pathologic because it's just part of what happens. But it's abnormal to have large infarcts in the center of the parenchyma, okay? And this one is very large, right? This is a small little disc we see here. There's not that much to it with this large infarct. And this one, the central hemorrhage, they are associated with conditions very similar to placental abruption. And what's happening probably is there's a weakening of the decidua and the vessel, and you're getting an abruption into the parenchyma. Instead of one that separates the placenta above, it's like a little mushroom cloud that's going into the parenchyma and causing this compression and infarction of the adjacent placental parenchyma. So the underlying pathology of maternal vascular malperfusion in many cases, especially for cases with growth restriction, is poor transformation of the maternal vessels for pregnancy. So in normal pregnancy, it is incredible the amount of dilatation that goes on in the vessels. The veins become huge, the arteries become huge, and the ones in the placental bed actually undergo trophoblast-mediated remodeling, right? So trophoblasts are a special cell of the placenta itself. They go down and they invade the maternal vessels and they remodel them for pregnancy. They make them these big, wide open fibrous tubes, and the trophoblasts stay in the walls and keep them that way. It seems that the pathology of preterm preeclampsia, especially severe preterm preeclampsia, this process, this is showing you a first trimester, all these are trophoblasts inside the mother's maternal spiral artery, and they're going to plug it up and then totally remodel them. This process didn't occur well, and they remain these small muscular vessels. And when that happens, they are susceptible to acute fibrinoid necrosis when she's ready to deliver, when she goes into the full severity of preeclampsia. But you can also see this pathology of the fibrinoid, decidual arteriopathy, fibrinoid necrosis, in some babies with small for gestational age growth, and the mother doesn't have symptoms of preeclampsia. So it's interesting, but there's an underlying physiology of the vessels not remodeling appropriately. So when they remodel, they're no longer susceptible to epinephrine, norepinephrine, causing to squeeze, whenever mom's stressed, right? They're just these wide open tubes ready to accept flow all the time. But when they don't remodel, then you've got constriction. So that can actually mean less flow, but at a high velocity. So we call it malperfusion instead of just underperfusion, because it may not be that it's less blood, it may just be that the dynamics of the blood flow are inappropriate. So this can happen, again, like I said, in women with preeclampsia, but also women with pre-existing vascular disease, especially obesity, chronic hypertension, diabetes, all conditions we see associated with neonatal encephalopathy. So this is just looking at villus development, and then I'm contrasting this to show you what happens in the case of accelerated maturation distal villus hypoplasia. So normal villi, you've had your chorionic plate vasculature going into these stem vessels, branching out into intermediary, and it's like a tree. And these little outpouchings are like the leaves. That's where the gas exchange occurs, right? It's extremely similar. So these little outpouchings are the distal villi, and that's the functional place for gas and nutrient exchange. In distal villus hypoplasia, it's like looking at a very sparse tree with only a few leaves, right? And the leaves that you got are tiny. So it doesn't undergo the same amount of lush branching, and you get very, very small villi. Instead of this normal angiogenesis where you have lots of coiling in those little villi, sometimes you'll just have an out and back, just one capillary loop. And we call that distal villus hypoplasia.
This is a villi placenta, not a lump.
Placenta, right, but it's so much like the lung, isn't it? Yeah, very, very similar. I think about it. And there's so much about normal lung physiology that may be going on in the placenta and we don't know yet, like VQ matching. You know, sometimes you see changes that it looks like the fetal vasculature is saying, this area isn't getting any good blood flow. I'm just going to shut down these vessels and save the blood for other areas. So this is what we see histologically. So at 28 weeks, right, when you might see a baby born, SGA, severe preterm preeclampsia, you're supposed to have them, the villi are still supposed to be in growth mode, right? So they're immature. Some of the vessels are close to the syncytial trophoblast, but the trophoblast layer is still kind of thick. It has regular nuclei instead of knots, and there just aren't that many capillaries in there, right? So at this many weeks, the villi are not ready for gas exchange, just like the lungs aren't ready for gas exchange. In distal villus hypoplasia, in contrast, they're really small, and you do have a lot of knots, and you have places where the capillaries are right up against the membrane, as if they are trying to make the most out of gas exchange early. So these two are the same gestational age, but strikingly different looking. So this placenta is going to be smaller, which makes sense. It's got less bulk than the one that's continuing to develop in growth mode. When these little villi undergo fibrinoid necrosis, these are the ones that are going to show the abnormal umbilical Dopplers as well. So absent end diastolic volume, absent end diastolic flow. And that makes sense because instead of having this large vasculature to relax in and keep the flow going, you've just got these tight little ends, blind ends, right? And so there's resistance. Okay. So that's maternal vascular malperfusion. Other big category is fetal vascular malperfusion. So the previous literature for this was known as fetal thrombotic vasculopathy. At the Amsterdam consensus, they decided to change the terminology, and this happens a lot in academic pathology. People just change the names, and then you get to publish a whole lot more papers because you just changed the name. And okay, so I appreciate they made the change because not all cases are really due to thrombi. You know, the fetal vasculature may occlude for other reasons than just thrombi. And you can see these changes sometimes if the baby's severely anemic, that it's like an ischemic change, right? And it's not because they're thrombi, there's just not enough oxygen getting down there. Okay, so the Amsterdam consensus categorized two types of fetal vascular malperfusion. I got a little bit of an issue with it because to me, when you put out a consensus statement, your changes need to be based upon a well-established literature that shows reproducibility, that shows everybody can make the diagnosis in the same way. But they took a little bit of a leap of faith. They put it into segmental and global. It makes sense that you should see differences between a segmental lesion, meaning you got a thrombus in one part of the placental tree and it affects everything downstream, but the rest of it's okay, versus the cord's occluded and the whole placenta is affected, right? So it makes sense that there should be a difference. We just don't have an existing literature yet, certainly not one yet, that can teach everybody how to make the diagnosis. So segmental lesions, though Ray Redline led an excellent group from the Society for Pediatric Pathology where they all agreed, yes, we can agree that this lesion is a lesion, we can all recognize it and so forth. But then with the global lesions, it was kind of based upon the expertise of a few members, and it hasn't yet had that same kind of vetting, really, to show that it's reproducible. So segmental lesions, they're thrombi that are easy to recognize and diagnose, or these changes in the villi that may be avascular or show the vessels are disintegrating, getting ready to be avascular. Global lesions, they describe ectasia of the veins. That can depend a little bit on interpretation, fixation, how the vessel was sectioned, but you know, with some people's expertise, they've had enough experience that they can call it when they see it. Intramural fibrin deposition in large vessels, this overlaps with what we studied as large vessel thrombi, and small foci of avascularvilli. And this is interesting to me because Ray, along with Karen Nelson, they did a recent study on neonatal encephalopathy and showed a significant amount of this global pattern of fetal vascular malperfusion, that it was real. In our study, where we took the changes of fetal vasculopathy and looked forward prognostically, well, how many of these, we've got all these placentas with these changed, what happened to the babies? We didn't find that small foci of avascularvilli meant anything. So I'm not sure, I would love to, I'm just going to go head down the street so we can head to head over cases and make sure we're calling the same things, you know, just to understand, because we did have that difference. Okay, fetal vascular malperfusion is associated with cord changes. When we talk about coiling, we're talking about this, right? So, and normal coiling ranges from 1 to 3 coils per 10 centimeters of cord. Hypercoiled, they're tight, right? You can see them. They are especially pathologic, and you usually only see this in demise cases when you get strictures between the coils. Okay. When we talk about cord insertion, we mean where does it touch down on the plate? The vast majority of placentas have an eccentric insertion, rare ones are central, and these are the pathologic 3. So some of our large series of neonatal encephalopathy showed associations with marginal or velamentous cords. Furcate is so rare you're never going to see it turn up in a study because there's just too few cases of it. But this is fairly common, marginal and velamentous cords. They're vulnerable. These vessels, the marginal, you can twist there and they're not protected by Wharton's jelly. Certainly velamentous, these long vessels are very susceptible to compression, especially if there's vasa previa. And there's some suggestion that just the flow itself through these eccentric, marginal, and velamentous is not as efficient as putting down the cord towards the center of the disc. That it just doesn't distribute as well and get through as well because there is an association with growth restriction in those cases. But again, if you look at a huge number of cases, just all comers, not selected babies, you may find the vast majority of these kids are fine. So this is a case, this was actually a demise case. The cord's getting very red because all the blood is leaching out into it. But this was an undercoiled cord, so there's almost no twists there. And there's a thrombus right up here in one of the proximal chorionic plate vessels. So this is what we're looking up there in the chorionic plate. And on cut section, these are avascularvilli. So it's like an infarct from the fetal side. So they'll be pale, but they retain their granularity. So those are the gross changes. Microscopically, in those big vessels, like the one from that case, we see this fibrin accumulating in the wall. Sometimes when it's old, the thrombus calcifies. And you may rarely see it actually be occlusive in the lumen. Usually they're not. Usually they're in the venous side of the circulation and they're not occlusive. In the villi themselves, the reason this is so significant is you're not getting any gas or nutrient exchange out of these. They just become avascular. They're just dead ends, dead branches of a tree, right? So in the older literature, when we looked forward from cases with the diagnosis, only cases that had been deemed high grade with large foci, multiple large foci of these avascular villi had an association with adverse neurologic outcome. But in their definition of global, multiple small foci, not necessarily accounting for a large proportion of the tree, was significant. So we'll see. Another big pathology that you'll see in the literature is delayed villus maturation. And a lot of this came out of the Dutch studies. Fetal vascular malperfusion, Ray Redline, was really a leader in that and helping people recognize that and put that out there as a pathologic change. Delayed villus maturation, especially this villus maturation defect, meaning the capillaries aren't getting to the syncytial trophoblast layer for optimal exchange. This was really Peter Nichols in the Netherlands that pushed this. So by definition, we're only seeing delayed maturation in a term baby because the immature ones, it's too hard to tell whether they're immature for 28 weeks. You know, they all look immature. It's just too difficult. These cases, you often have a low birth weight to placenta weight ratio, so you get this big, bulky placenta, right? And the baby might be normal, or a large for age baby where the placenta is even larger. So if you think teleologically, These placentas are probably inefficient and just keep bulking up and up to try to make up for their inefficiency. That's what people call them in the literature. The most characteristic, so this pathology is most characteristically seen in cases of maternal obesity, gestational diabetes, as well as excessive weight gain during gestation. So many times I see these cases come across and I'm like, wow, she must be diabetic. It just looks so immature. And then she's not, by screening criteria at least, but she may have a BMI of 40, you know, so there's a lot of overlap here. It's not just hyperglycemia during pregnancy. There's some other physiologic thing that's happening. And I always wonder, because a lot of these babies seem to have a poor respiratory course, are their lungs immature too? Like, I always wonder that. Are the two going in parallel? So these villi are just poorly suited for the demands of term. And the difficult thing is immature villi and edematous villi can be indistinguishable because they're both big and pale and look like they're full of fluid. So there's a lot of controversy, I mean, especially with people with medical legal practices. I don't have one, but whether or not this is edema versus immaturity, right? Because it could be edema from a cord problem. Well, it's immaturity because of a mom problem, you know, and it's like, look, it is what it is. If we can't tell the part, I often just call it edema/dysmaturity because I don't think we have a way to necessarily tell them apart. And that's as old as the hills. If you look back in the Benershka, you know, back when he was writing in the Brigham, you know, they would describe cases of RH disease, right, where edema makes sense. The baby's hydrophic. They would call it immaturity. Right? And then you could have the opposite situation. So it's like, this is all over the place. If we look back to our modeling, so again, this is based on 3D. They're castings from EM that Peter Kaufman did in Germany to look at, which to me really helps to understand the physiology. This is our normal branching. In delayed villus maturation, it's bulky, there's less terminal branching, and they're really big. So they just stay large. Histologically, this is what a term villus should look like. It's maximized for gas exchange, right? We have these, just like in the lung, you've got this really thin membrane between the place where you're supposed to be exchanging everything, right? So the capillary and the syncytial trophoblast, this should be very thin, no nuclei in the way, no stroma in the way, so they're ready to go, right? That's normal. In delayed villus maturation, they are not, right? You've got all this extra stroma and extra cells, and where in the world can you see, maybe here, a capillary coming up against the syncytial trophoblast to be able to do gas exchange, right? So this is an extreme field, but in general, that's the problem. Here's another example of a field where, is that immaturity or is that edema? I think you'll find people calling it different ways. That's one I just call edema/dysmaturity because, you know, they are very big. You can kind of suggest, well, it should be edema because everything's so spaced out. It can just be very hard to actually make that call with any precision. There has been some diagnostic drift and overlap between these changes with changes of fetal vascular malperfusion. There are some experts who believe this is part of fetal vascular malperfusion. There's one study associating this change where you don't have, even though they're smaller, they look pretty mature, but you don't have apposition of the capillary to the syncytial trophoblast membrane. They associated that with hypercoiled cords, and they suggested, well, maybe something about fetal perfusion is affecting this development. Maybe. I'm not ready to throw away all of our experience with diabetes, obesity, and these other factors and say that it's a problem with the cord, because to me, we could be missing a big part of public health if we just put it all on a cord issue. Okay, that's fetal vascular malperfusion. Another big category, Villitis of unknown etiology or chronic Villitis. This is a condition where maternal T lymphocytes invade the villus stroma. It's really common to have minimal involvement at term. It's very uncommon to have diffuse involvement, okay, meaning over 30% of the villi are affected. It's very uncommon preterm. When you see it preterm, it's usually a growth-restricted baby. 90% of the cases we attribute to an alloimmune response of the maternal immune cells to fetal antigens. Personally, I think this is a mechanism that evolved to rid the trophoblast of, get rid of them in the uterus, right? At some point, you've got to turn on the immune response to them. They've got all the vessels wide open. She's going to bleed to death if you don't get rid of them, right? You've got to do all this remodeling and get rid of things. So personally, I think it's appropriate at term to see a little bit, but this response can get turned on preterm or get out of control, and it associated with a bad outcome. This is what we're seeing histologically. So these are all maternal lymphocytes, histiocytes. They are going right along the border where the cytotrophoblast, the trophoblast that will replenish the syncytial trophoblasts, live. The fetal vasculature has an interesting response to this inflammation. It starts to involute and shut off. And you see these little dots, that's choriorexis. So it's the same changes functionally that you would see in fetal vascular malperfusion. So in our study of fetal thrombotic vasculopathy, we included cases with this. And when you got a lot of these changes, it's significant, right? Which makes sense. You're shutting down the vasculature to a large amount of placental parenchyma. My pet theory as to why this would evolve, why would the vessels disappear because there's inflammation? If you look at cases of like coccidioides immitis in the placenta where there's a lot of inflammation, those fetal vessels go, whoosh, they disappear. And it makes sense because you probably don't want the infection getting into the fetal vasculature, right? So teleologically makes sense. This is a case with extensive involvement that I get a notice in my box, Dr. McKenney, will you release these slides? Some lawyer wants them, because this was a child, they're obviously suing because the kid had CP, when they were 4 or 5 years old. Looked back, and this placenta had been called normal before we had a perinatal pathology service, and it's extensively involved by chronic velitis. It was not normal. So this is something that we've had to teach general pathologists how to recognize. They often don't. Most people get very little placental pathology training. Gabrielle, I think that study actually came out of Rochester. That showed the number, you weren't part of it, but the number of placental pathologists that didn't recognize chronic velitis. All right, then there are these other lesions that are extremely rare. They're never going to show up in a large case series just because the frequency of them is so small. But if you have a patient with it, there's a significant risk of problems. Meconiumassociated vascular necrosis, massive perivilus, fibrin deposition, chronic histiocytic intervilasitis, and chronic fetal maternal hemorrhage. You're dealing with that before I see the placenta. Meconium-associated vascular necrosis is very interesting to me. This is a lesion that came out because of people with big medical legal practices, right, who see a lot of cases. They're the ones that first recognized, wait, this is a thing. Something's going on, that in these cases of meconium, the vascular smooth muscle cells are becoming apoptotic. So they're dying, rounding up, and this is bound to be dysfunctional because I see it in all these cases with bad outcome. What's interesting to me, and these are meconium macrophages here, this is a chorionic plate vessel, and these are the apoptotic cells, is not every case with extensive meconium exposure shows this change. For example, this one, I have pigmented histiocytes all over the place. These are sitting right on the muscle, and I don't see it. So there must be something about the host. I would guess that some people, their response to the meconium is to have this toxic effect. And others, they have a lot of it, it doesn't show that effect.
Is it how long they were exposed, maybe?
I don't know, because you see some, and actually there was a study that Rebecca Berrigan did where they were looking at meconium-associated vascular necrosis, and they saw similar outcomes in cases with meconium-laden histiocytes in the umbilical cord without meconium-associated vascular necrosis. So that may just be a marker of prolonged exposure, because that's usually the last place you start to see them is in the stroma of the cord. So it may just be that it's prolonged meconium exposure is what's associated with outcome versus this toxic effect specifically. And the prolonged exposure may be a marker of something else that was happening, right? It's why meconium was passed. This is the other rare condition, massive perivilus fibrin deposition. By definition, you're knocking out over 50% of the parenchyma. The villi get choked off with fibrin. They can't be functional. Chronic histiocytic intervilasitis, another fascinating lesion, a recognized cause of recurrent pregnancy loss. This is a maternal, it's associated with maternal autoimmune conditions, where they're just getting a handle on what kind of therapies might be able to help these pregnancies. But it's a very high rates of fetal loss and fetal demise. And in survivors, poor neurologic development. Chronic fetal maternal hemorrhage, you know what to expect there. We have this bulky, extremely pale placenta because the baby is so severely anemic. Each of these tiny little foci of hemorrhage microscopically are actually the baby's blood going into the intervilus space. So a lot of times we try, and I know this has been tried in the past, to associate neurologic injury with chronic processes versus acute processes. And there's been, chronic processes, you get the basal ganglia, thalamic, versus acute, you get the white matter watershed. That's not always sorted out well in in studies. Acute processes are what we talked about, choriamnionitis, certainly an acute cord compromise, that's acute, an abruption, that's acute. Subacute processes were the changes we were talking about, maternal vascular malperfusion, right, that lead, basically all the subacute and chronic processes, most of them lead to a small placenta and a small baby. They've been chronically compromising placental growth. So in addition to the maternal vascular malperfusion, chronic velitis, delayed villus maturation is different. It's a chronic process, but it's usually associated with placental overgrowth, not undergrowth, and there are very few markers in utero to say this is a case that's at risk, unless you recognize that the patient's gestational diabetic, or that you see the mother is obese and needs frequent monitoring. Abnormal coil insertion coiling, you can consider, it's been there from the beginning, so it's a chronic process. So if we try to look at the literature of what's been published on placental pathology and outcomes, you can approach it from different ways. It's fortunately a rare occurrence that babies are born with neurologic injury. So you may start with taking all cases of babies with neonatal encephalopathy in the NICU and then go back and see what's in the placenta and then select some controls. You may take all cases of babies treated with hypothermia or results by MRI, or later in a registry by the diagnosis of cerebral palsy. And then also a lot of our early studies came from the expertise of people who did a lot of medical legal consultations. The opposite way to go is to say, okay, well, we recognize these findings may be significant, so you go back and say, let's look at all the placentas with that change and see what happened to the baby. So with these, you usually find that the positive predictive value is not that strong, with exception of those very rare conditions. When you're trying to look at these, a meta-analysis would be almost impossible because they vary in design, whether they're a case control study or an observational study. They vary in the study population. Some of them included mild as well as moderate to severe neonatal encephalopathy. Some of them only included babies treated with cooling, or some of them were from a registry. They vary in the methodology of placental exam. So this is why that Amsterdam consensus was so important, because we wanted to try to set a standard and say, okay, everyone who's doing anything with placental pathology, please make sure you do this at a minimum so that we can at least compare studies. So some of them only looked at the gross of the placenta. Some of them looked at the gross and microscopic, but only a subset of variables. They may not have known how to diagnose fetal thrombotic vasculopathy, and so that wasn't included, or delayed villus maturation. So use of these consensus criteria hopefully will improve this. And then finally, what they're measuring as outcome varies. Some may be looking at the diagnosis of cerebral palsy or death. Some may be looking at neurologic development at 2 years. Some may be just looking at the severity of neonatal encephalopathy, or some may be looking at MRI findings. All right, so the most recent one we have, Karen Nelson was a co-author as well as Ray Redline on this one. It's in press in the Journal of Pediatrics. I was lucky that Ray shared this with me, because as I was saying, well, how did you diagnose global FVM? Right, so he said, it's real. So this was that study. They had 73 babies with neonatal encephalopathy in the NICU. This included all grades. So this included babies with irritability to babies who were obtunded. It was a whole range. Their controls were very nicely consecutive births, because this happened to be a place that studied every placenta. So that's really nice. That's rare to have that kind of control population. So they were randomly selected. So some of the controls may have been completely normal babies. Some of the controls may have been babies with chorionitis, but it's a good, definite matching. The outcome they looked at was whether or not the placental changes were associated with the diagnosis of neonatal encephalopathy. Okay, all grades combined. And they found the pathology of this global change of fetal vascular malperfusion was associated with neonatal encephalopathy. So that's the one that is multiple small foci of avascularvilli and thrombi that are not occlusive in the veins, what Ray calls intramural fibrin deposition. So this has some overlap with previous studies. It's just you can't exactly look at how many cases had thrombi and small foci versus small foci over. Once you start trying to dissect into the nitty-gritty, you end up with too small numbers to have any power. So, in 2016, there was a study of the cases included 41 patients with neonatal encephalopathy that were treated with hypothermia. So these were all moderate to severe. And the controls were 100 term healthy infants. And their outcome was looking at the diagnosis of cerebral palsy or death at 12 months of age. They found that placental abruption associated with the diagnosis of cerebral palsy or death, and a velamentous marginal umbilical cord insertion, especially with abruption, was associated with hypoxic ischemic encephalopathy. So one problem in trying to compare this study with the other is the changes of fetal vascular malperfusion were not even a part of the histologic criteria for what they were evaluating. So their methods were different. 2013, this was a Dutch study where they had 95 babies with neonatal encephalopathy in the NICU and looked at their MRI findings. They were looking to see what associates with basal ganglia versus white matter watershed involvement. They found that chronic velitis was associated with the basal ganglia changes, and hypoglycemia, as well as delayed villus maturation. And there's reason to think those two go together, right? If they're often moms with gestational diabetes and LGA babies, was associated with the white matter watershed injuries, with or without basal ganglia involvement. And it's interesting to me to look back at these studies, right? Because, Ray described fetal vascular malperfusion really. He's the one that gave it a literature. So his study shows that. And Peter Nichols described in best detail delayed villus maturation, and his study shows that. So it's as much as we try to be objective, there's always some amount of subjectivity, as excellent as we try to be in terms of what your eyes see. What stands out to you. I wish it weren't the case, but it's true. 23 neonatal encephalopathy infants treated with hypothermia. This was a 2010 study. There were no controls. They looked at what happened on MRI. This is interesting to me. It's a very small sample. It's just 23 patients. Acute chorionitis, fetal vasculopathy, as well as meconium in the chorionic plate were all associated with hypoxic injury on MRI. And interestingly, of those babies treated with hypothermia, the ones with a small placenta actually were fine. Now, it didn't necessarily say why it was small, but you assume that they were all small because of chronic velitis versus small because of underperfusion. Many, many more are going to be small because of malperfusion. So that is echoed a little bit in this study, which is a huge number of patients from a CP register. Dr. Nelson was on this one also, where the outcomes were just diagnosis of CP or death. They weren't looking at histology. They were only looking for, was an infarct found on the gross exam of the placenta or not. They didn't count how many infarcts or anything like that or where they were, just is there an infarct or not. They found that yes, infarcts were associated with the diagnosis of cerebral palsy compared to controls, which were 491 not on the register. Infarcts were also associated with deaths, but they had the most significant association of with cases of cerebral palsy with spastic quadriplegia. But interestingly, cases with fetal growth restriction and preeclampsia had a lower risk of CP. So it still makes me wonder what's going on in the cases of the small placenta, small baby. Are they somehow a little bit more fit to survive that immediate period? We know there are downstream consequences in life with hypertension, obesity, all these other things, but it's kind of interesting that there may be a certain survival advantage if they make it through with enough placenta to get born. This was a case where they only looked at cases in the registry, no controls, and they found a lot of cases with choreo and a heavy placenta. Hard to know how helpful that data is if you're not comparing it. And then another study where they looked at, this was at Parkland in Dallas, 120 term babies with acidosis and neonatal encephalopathy. There were no controls, but they were looking at what associated with severity of neonatal encephalopathy, death, or the diagnosis of a adverse neurologic development outcome at 24 months. So they found that chorionic, chronic vilitis were both associated with higher grades of neonatal encephalopathy, and that chronic vilitis especially was associated with poor neurologic development outcome. In their study, they did not evaluate delayed villus maturation or fetal thrombi. So they looked at Avascularvilli, but not fetal thrombi. So again, it's hard to say what's significant and what's not significant when people were looking for the same things across the board. And this is just the full references from those studies. Some other interesting findings that came out of those studies. Babies with the delayed villus maturation tended to have hypoglycemia. And again, I think that makes sense because that pathology is more commonly seen in gestational diabetes and obese patients. Babies with chorionitis were more likely to have metabolic acidosis that was persistent. Babies with chronic vilitis and basal ganglia lesions, we talked about that. And then the small for age baby with the small placenta tended to have a better clinical course and normal MRI. So the big picture, when we're thinking about neonatal encephalopathy, I trained at Stanford. Every Stanford pathologist shows a Venn diagram because everything is relative to us. Everything's on a continuum, and we recognize that multiple factors are involved. So you'll always see these from us. There's going to be maternal factors. There's going to be circumstances of the delivery. Fetal genetics, we're now starting to recognize some 15% of cases will have a gene mutation. We don't yet know what the significance of those mutations are. And then the placental pathology itself. In that overlap, you're going to have patients that are vulnerable to neurologic injury. We can't point to one pathology that is associated. Thank you.